Buenas tardes. Vamos a seguir con la sesión de esta tarde y yo creo que es una sesión de lujo. Es una conferencia magistral para la cual tenemos la suerte de contar con una de las personas que más ha contribuido últimamente al avance del tratamiento de la insuficiencia cardíaca desde el punto de vista de los ensayos clínicos. Yo creo que el profesor McMurray no necesita presentación. Cualquiera que trabaja en el campo de la insuficiencia cardíaca está acostumbrado a ver su nombre en la cabecera de gran parte de los últimos ensayos en insuficiencia cardíaca, y yo creo que en base a eso la conferencia que nos va a dar hoy va a ser, yo creo que muy ilustrativa, porque es una conferencia desde la experiencia, es una conferencia desde la perspectiva del que hace historia. Y yo creo que además es también muy oportuna, porque si la medicina basada en la evidencia empezó a andar hace unos años, empezó a andar de la mano de los ensayos clínicos y en particular de la mano de los ensayos clínicos en el campo de la medicina cardiovascular y en particular de la mano de los ensayos clínicos en la insuficiencia cardíaca, porque al margen del rigor, de la metodología, etcétera, la insuficiencia cardíaca, como otras patologías cardiovasculares, tiene una cosa que tienen pocas enfermedades, que es que tiene endpoints absolutamente claros, no ambiguos, objetivos y bien definidos. Yo creo que la medicina basada en la evidencia le debe mucho a la medicina cardiovascular, a la medicina de los ensayos clínicos en la insuficiencia cardíaca, y le debe mucho al profesor McMurray. Por favor.
Thank you very much for the introduction. I apologize for not being able to speak in Spanish. I'm even more embarrassed to say that I have a son who lives in Madrid and teaches English, but he never taught me how to speak Spanish. So, thank you for inviting me to this meeting. I'm very glad to be here. I just want to make one thing clear so that we don't have any discussion afterwards. And the message is on the slide. So why are we talking about clinical trials? Well, hopefully you don't need to be persuaded why we should talk about clinical trials. But it was very interesting a few years ago when the British Medical Journal carried out a survey to celebrate being one of the oldest medical journals in the world. And they surveyed the readership to ask what were the most important medical advances of all time. And you can see here the top 15 things that were selected by the readers. And in fact, a very similar poll was done by the NIH in the USA, came up with a very similar list. And as you can see, one of these was randomization, a very simple but very brilliant concept. And of course that is the basis of the trials that we do today. And I'll come back to that later on, why it's such an important concept that I'm worried is in danger of being forgotten about today. A lot of people don't realize the importance of randomization. So I was asked to talk about what was the contribution of randomized controlled trials to progress in heart failure therapy over the years. And I thought I would look back a little bit, then I would look at what's happening today, and then I'll say something about what to look forward to. So this is sort of where I started. I graduated from medical school in 1983, and that was a very exciting time because ACE inhibitors had just been discovered and were being used. And then of course in 1987 the first ever trial to show that you could improve survival in heart failure was published. And most of you here, I realize, are not old enough to remember the days before ACE inhibitors. But people with heart failure were really regarded as people who had a very short time left to live. This was a universally and rapidly fatal disorder, and I believe that we've really changed that. And this was the first wave of the trials that were conducted over the past 30 years that have really made such a huge difference. ACE inhibitors, of course, the only ACE inhibitor actually shown to be of benefit in heart failure is enalapril, and that becomes relevant, as we'll see in a few moments. And then, of course, the beta blocker trials. And the great thing about heart failure in clinical trials is we don't generally have one trial. We often have multiple trials. Showed you 2 ACE inhibitor trials. These are the key beta blocker trials. But there are others, and I always think that one trial that gets overlooked, that was such an important trial, was the COMET study. Who remembers the COMET study? A comparison of carvedilol to short-acting metoprolol, not the long-acting formulation that was shown in MERIT heart failure to improve survival, but conventional short-acting metoprolol that you have to prescribe 2 or 3 times daily. And you can see here that carvedilol was superior to metoprolol. It reduced all-cause mortality by 17% compared to metoprolol. And why is this important? This is important because it emphasizes that our practice should be based on the drugs that are used in the trials and the doses of those drugs that are shown to be effective. And again, this is a message that is often lost. We should be practicing evidence-based medicine, which means evidence-based treatment that corresponds to the drugs and the doses used in trials. If you think you can use any beta blocker, this study tells you that you might be wrong, because clearly carvedilol was better than short-acting metoprolol. And then laterally, of course, the emphasis heart failure trial with a mineralocorticoid receptor antagonist, a trial where we tried to fill a very specific gap. Again, something that we're great at doing in heart failure. We knew about spironolactone in patients with severely symptomatic heart failure. What about patients in NYHA class 2? What about patients with mild symptoms? We did a trial just in patients with in NYHA class 2. And MRAs are extraordinary drugs. They have an enormous benefit in patients with heart failure. This is the combination of cardiovascular death or heart failure hospitalization. This is all-cause mortality, even when added to an ACE inhibitor and a beta blocker in patients who had mild symptoms, patients that some people might describe as stable. As you can see here, there was a 22% significant reduction in all-cause mortality. Not many drugs do that. Not many drugs have such an effect. Why am I picking out mineralocorticoid receptor antagonists? I'm picking out mineralocorticoid receptor antagonists because of all the pharmacological therapies, at least until recently, that we had that were effective. This is the one that was most underutilized. And there is a very strange pattern of underutilization of this type of treatment around the world. And we're not so bad in Western Europe, and I think actually Spain is a particularly good country for using mineralocorticoid receptor antagonists. But if you look at, for example, the United States and Canada, these drugs are much less used. And in fact, one of the problems that we still have in medicine is the translation of the results of our trials into clinical practice and understanding why that takes so long, understanding what are the barriers to doing that. And then, of course, we come to the present day. The most recent of our new treatments shown to improve mortality in heart failure was a treatment that we conceived not to block all the harmful neurohumoral systems that we've just talked about, the sympathetic nervous system, the effects of angiotensin II, the effects of aldosterone and other corticosteroids, but a treatment that instead was designed to try and augment the beneficial neurohumoral systems that operate in heart failure. Could we augment the effects, for example, of natriuretic peptides and other systems that are vasodilator, that inhibit pathological growth, that augment sodium and water excretion? And as many of you know, after, believe it or not, 25 years of trying, we eventually discovered how to do that using an inhibitor of an enzyme called neprilysin. And I'm not going to go through the details of this, but as you know, this enzyme breaks down natriuretic peptides and other vasoactive substances. And by inhibiting this enzyme, we increase natriuretic peptide levels, the levels of other things, and we're learning more and more peptides that may be augmented by blocking this enzyme. And in doing this, we were able to further reduce mortality. Now, one of my great regrets about what we did when we did Paradigm Heart Failure, the trial with this agent, is that I don't believe we explained clearly enough what this drug was and what we were doing, because a lot of people think this is a substitute for an ACE inhibitor or a substitute for an angiotensin receptor blocker. It's not. It's not an alternative. We're adding a new drug. We're adding a neprilysin inhibitor. And this interpretive problem also, I think, in some ways explains why I believe the guidelines aren't correct, because neprilysin inhibition has got nothing to do with mineralocorticoid receptor antagonists, nothing to do with beta blockers. It's a completely separate type of treatment, and there is no reason to believe that it would not be additive and complementary to everything else that we do. And the trial, as I said, that we conducted to demonstrate the benefits of sacubitril valsartan was Paradigm Heart Failure, adding a neprilysin inhibitor in one group to conventional treatment, and the other group just received conventional treatment. Of course, in the control group, the RAS blocker was enalapril. In the neprilysin inhibitor group, the renin-angiotensin system blocker was, of course, valsartan. And that goes back to those two trials I showed you at the very start, Consensus and Solve treatment. They used enalapril. That was the regulatory gold standard for blocking the renin-angiotensin system. We had to use enalapril as our renin-angiotensin system blocker. And again, you've all seen this result before, and we were very pleased. That was the first new class of treatment to reduce mortality in heart failure for 15 years, which was a long time to have to wait to get a new treatment. And as a result, today, I believe that this is what our standard pharmacological therapy, what the four pillars of treatment should be in patients with heart failure and reduced ejection fraction. And with those four treatments, some of you have seen this meta-analysis before, with those four treatments, really we've done something astonishing, I would say. We have reduced mortality, all-cause mortality, by 63% in this network meta-analysis. And compared to back in 1983, when I graduated from medical school, things have changed completely and utterly. And what we need to do is to make sure that's the case going forward. Now, I've focused on pharmacological therapy. That's my interest. I don't want to diminish the importance of devices. We have 4 trials with cardiac resynchronization therapy, these 2 being the most recent trials conducted in patients with mild symptoms, trials conducted in patients who had an implantable cardioverter defibrillator, and again, trials showing improvement in outcome. And that brings me to the implantable cardioverter defibrillator because, of course, we had one seminal study showing that an ICD compared to amiodarone, compared to placebo, could reduce mortality in patients with heart failure and reduced ejection fraction. But of course, this trial was done a long time ago. It was published in 2005, but it was actually started, I think, in 1999. And things were different there. And if you look at the top of the slide, you can see that not everybody was on a beta blocker. Mineralocorticoid receptor antagonist use was not even collected. So all we know from the SCUD-HEFT database is whether people were taking potassium-sparing diuretics, which is how in this trial mineralocorticoid receptor antagonists were classified, probably along with amiloride and triamterene, but only 20% of patients were in a mineralocorticoid receptor antagonist. And that brings us to a very brave and I think interesting study carried out by our friends in Denmark, a trial appropriately called the Danish trial. And in that trial, they looked at patients with heart failure and reduced ejection fraction of non-ischemic etiology because they believed that the evidence for putting an implantable defibrillator into patients with non-ischemic heart failure was not strong. And as you know, in that trial, there was no reduction in all-cause mortality. But if you look at the top of the slide, these patients were treated completely differently. Almost everybody was on a beta blocker. A lot of patients were on a mineralocorticoid receptor antagonist, and indeed a lot of these patients had cardiac resynchronization therapy. So that raises some very interesting questions about the future. Do we have to think about redoing some of our trials? Are some of our older trials, what you might call legacy trials, perhaps no longer relevant? ICDs is one example of that, but of course perhaps the best example of all is digoxin. There's one study demonstrating benefit from digoxin, but it was done at a time when we didn't use beta blockers. It was done at a time when we didn't use mineralocorticoid receptor antagonists. And there are some attempts, in fact there are two modest-sized studies underway at the moment, trying to see whether in the modern world that we live in today, digoxin is still valuable. And the other thing the Danish trial highlighted is something that will become very important to all of us who do trials, but also all of us who look after patients in the future, and that was an interaction with age. In this trial, it looked as though ICDs were beneficial in younger patients, but had no benefit in older patients. Now, I'm not just saying that because some of us are getting older, and I'm concerned about myself. I'm concerned because, of course, the population's getting older, our patients are getting older, and I don't think this is about age. I think this is about comorbidity. And in fact, a very similar phenomenon was demonstrated in a surgical trial, the STITCH study, looking at coronary artery bypass grafting. And as you know, in the extension study of STITCH, there was a reduction in all-cause mortality with surgical coronary revascularization. But some of my colleagues in Glasgow have looked at this database in more detail, and they found exactly the same thing as you see in Danish. Because what you can see in this figure shown by the green line is a continuous hazard ratio. It's below unity, it's below 1, below the red line in people roughly under the age of 60, but once you get older than 60, there is no apparent benefit. And again, that's probably not age, it's probably comorbidity. If you've got other diseases, you're more likely to die from a non-cardiovascular cause, and therefore a cardiovascular treatment cannot make you live longer. So in the future, I think we're going to come up more and more against this issue of comorbidity. Not only does it modify the effect of cardiovascular treatments and modify prognosis, but in fact in itself will increasingly be the target for treatments that we want to use in patients with heart failure, and I'll come back to that in a moment. So that's where we've got to. What's going to happen this year? Now, I'm sorry this is a very busy slide, but it is the background to one of two very large trials that will present over the next few months. This is the background to the Paragon heart failure trial, which is a trial with sacubitril valsartan in patients with heart failure and preserved ejection fraction. So now I've moved away from heart failure with reduced ejection fraction to talk about HFpEF. And on this slide, which I'm not going to read through, you can see the rationale for wanting to inhibit neprilysin in patients with heart failure and preserved ejection fraction. And there is a good rationale. It's very interesting because many years ago, John Burnett and colleagues from the Mayo Clinic showed that patients with diastolic dysfunction, HFpEF, had an abnormally low, a reduced natriuretic peptide response to a fluid challenge. And that was a curious finding. More recently, David Cass and colleagues showed that if you look at human myocardium, if you look at the hearts from patients with HFpEF, an enzyme that is responsible for breaking down cyclic GMP, which is a key second messenger in the natriuretic peptide pathway, this enzyme, PDE9, is upregulated. So these patients produce less natriuretic peptides, and when the natriuretic peptides bind to cell surface receptors and stimulate second messenger pathways, that second messenger is degraded more quickly. So there is a good rationale for using sacubitril valsartan in these patients, and it may be of interest to you, but at a very early stage of development are also PDE9, phosphodiesterase 9 inhibitors, potentially for the treatment of patients with heart failure and preserved ejection fraction. So this is Paragon, the design of Paragon, sacubitril valsartan versus valsartan. We had no obligation to use an ACE inhibitor in patients with HFpEF, so we chose a more direct comparator. You may be wondering why we put the control group on an angiotensin receptor blocker. I'll come back to that in a moment, but it's simply because most doctors are giving the majority of these patients a renin-angiotensin system blocker for some reason, probably hypertension, maybe diabetes, perhaps other reasons. So we have, with the help of many people in Spain and other countries, enrolled 4,822 patients with an ejection fraction of 45% or above. We've randomized them to sacubitril valsartan or valsartan. This is the largest ever HFpEF trial. We hope it will be the first positive HFpEF trial. We've published the design paper, we've published the baseline characteristics paper. The patients are quite different than patients with heart failure and reduced ejection fraction. You can see that they're definitely older. The average age is 73, so that's about 10 years older than the average age, for example, of patients in Paradigm heart failure. And you can see that just over half the patients are women. That's compared to about a quarter of patients in trials with HFrEF. So different patients than in our HFrEF trials, more typical of real-world heart failure patients. And this is the reason why we had to give these patients in the control group a renin-angiotensin system blocker, because if you look at recent HFpEF trials, the majority of patients with HFpEF are being treated with one of these agents. It's over 80% of patients in recent trials and in registries, and that is the reason why we had a valsartan arm in the trial. So I was just talking to Tony about this before this session started. Assuming our trial is accepted for a late-breaking presentation, which I hope it will be, then we will present the results of this study at the ESC Congress in Paris this year. So one big trial, perhaps, we hope, the first ever positive trial in HFpEF. The second study that you will hear about this year, so this is a big year for heart failure, is a trial using completely different sort of drug that was originally, of course, developed as a treatment for diabetes. The story behind these drugs is really fascinating. Goes back more than 100 years. A chemical called fluorescein was isolated from the bark of apple trees and was shown first in dogs and then in humans to increase urinary glucose excretion. But it was never taken forward because it caused gastrointestinal upset. And that was because that was a non-selective inhibitor of sodium glucose co-transporters. And one of those is found in the gastrointestinal tract. That is why fluorescein caused so much GI, gastrointestinal intolerance. But there is another one of this family of co-transporters that we believe is found only in the renal proximal tubule, or so it is said. And there it is responsible for uptake of filtered glucose. And for each molecule of glucose taken up, there is a molecule of sodium reabsorbed. If you block this co-transporter, you increase urinary glucose and sodium excretion. These drugs are diuretics as well as glucose-lowering drugs. But in a remarkably short period of time, we got 3 astonishing trials, I would say, amazing results, showing that these drugs also reduce the risk of heart failure hospitalization in patients with type 2 diabetes. And those 3 trials, which were in a broad spectrum of patients with type 2 diabetes, were recently supplemented by this 4th trial presented earlier this month, showing that in patients with diabetes and chronic kidney disease, there was also a reduction in heart failure hospitalization. In fact, a reduction in many different cardiovascular and renal endpoints. And actually, as you can see here, the magnitude of the reduction in heart failure hospitalization was huge, 39% relative risk reduction. So 4 large trials demonstrating reduction in heart failure hospitalization. But these trials were mainly about the prevention of heart failure. And where we need to go and where we are going is to find out whether these drugs can be used as a treatment for established heart failure. And then if you ask that question, you have to ask, is it only in patients with diabetes, or might they work in patients who don't have diabetes? Is it HFrEF? Is it HFpEF? Or is it both? Now, you may be wondering why we think this. Well, in these trials, there was a small subset of patients, about 10 to 15% of patients who had heart failure at baseline. It wasn't very well characterized. Although there's been something published recently about this, we really don't know what type of heart failure this was. But those patients shown in the upper panel of this figure seem to get the same benefit from SGLT2 inhibitors as the majority of patients who did not have a history of heart failure. Or you may also be saying, well, why would we even think about giving a drug that was developed for treatment of diabetes? Why would we want to give that to patients with heart failure who don't have diabetes? What is the point of giving a drug designed to lower blood glucose to patients with heart failure who don't have diabetes? And there are two reasons. One is that the effect of these drugs may be unrelated to glucose lowering. And if you look at the left-hand panel on this figure, if you look at heart failure hospitalization, those Kaplan-Meier curves separate almost immediately within just literally a few weeks of randomization. And that really doesn't fit with our concept of how lowering glucose reduces cardiovascular events, which is traditionally been considered to be a long-term metabolic benefit. This was a very rapid onset benefit. Maybe it was just due to the diuretic effect. Maybe these drugs are just very good diuretics, or maybe there's something more. And lots of people have speculated about what these additional mechanisms might be. These drugs do preserve kidney function. They do reduce decline in renal function. There are other speculative mechanisms. Again, Tony and I were just talking beforehand about the sodium hydrogen exchanger, and there is some experimental work to suggest an effect on that. One that is very attractive to many people is that these drugs may improve the metabolic efficiency of the failing myocardium. So it may be that these drugs have non-glucose dependent mechanisms. But even if they do just work by lowering glucose, that is still relevant to the vast majority of our patients with heart failure, because most of our patients with heart failure, whatever the phenotype, have got either diabetes or pre-diabetes. And if you look at the blue part of this pie chart, those are the people with a normal hemoglobin A1C. It's less than 1 in 5 patients. And in fact, those patients who have a normal hemoglobin A1C rapidly progress to develop pre-diabetes and diabetes. And that's a whole other interesting story. Why is heart failure so insulin resistant, so dysglycemic? But again, the majority of these patients could perhaps benefit from glucose lowering. And there's already 5 trials underway looking to see what the role of these drugs might be in patients with heart failure. And I will remind you that the first study of these drugs was published in 2015, 4 years ago. There are 5 large trials underway. 2 of them are in patients with heart failure and reduced ejection fraction. They're both enrolling patients with and without diabetes, one with empagliflozin and one with dapagliflozin. We have published our design paper for DAPA heart failure. Our baseline characteristics manuscript is in press at the moment. Again, a global study. I'm sorry Spain wasn't involved in this one. 4,700 patients from 20 different countries enrolled in a remarkably quick period of time. And as you can see here, 42% of the patients did not, 42% of patients had diabetes at baseline. 58% of patients did not have diabetes. So we will be able to test whether these drugs work even in heart failure patients, HFrEF patients who don't have diabetes. And again, if everything goes to plan and if the American Heart Association accept our trial as a late-breaking trial presentation, then we hope to present and publish these results at the American Heart Association Congress in November. So this is a big year for heart failure. This could really change things quite dramatically, even if just one of these two trials is positive. So to finish with, what else is happening? So what might the third slide in my timeline series show? This is my list. I'm not going to go through these. A lot of you have probably heard me talk about each of these trials before, but I've decided not to do that today. But I'm very happy if anybody's got any questions to talk about it after my presentation. But there's a huge number of trials underway at the moment, looking at all sorts of interesting molecules, and these really cover the whole spectrum of different things that you might want to do in patients with heart failure. And it's hard to keep up with this because literally in the past 2 weeks, this trial has started. This is another large trial, this time looking at a potassium-binding drug. And this is a very curious, but perhaps it's the way that we're going in the future. This is a trial looking at a potassium-binding agent to see whether that might facilitate the use of renin-angiotensin system blockers and mineralocorticoid receptor antagonists in patients who've either experienced hyperkalemia or at high risk of hyperkalemia. Might the potassium-binding agent allow the use or continued use of those life-saving treatments? So more trials all the time, lots of things happening. And again, I've focused on pharmacology, but other things are happening as well. And of course, some of you probably work, like my friends in Glasgow, like Mark Petrie, work on transplant units. And of course, not a lot's happened in the just over 50 years since the first successful human heart transplantation. But there is a little chink of light. There is an interesting new development, and that is an approach that might allow xenotransplantation, which had been discontinued as a line of research some years ago, might allow xenotransplantation to become relevant again. And the problem with the source of animal organs that we had considered as suitable for human transplantation, which was pigs, is that pigs carry retroviruses, and the concern was that these would jump the species barrier in immunosuppressed patients following transplantation. And now with CRISPR technology, it may be possible to remove these endogenous retroviruses. It might even be possible to make these pig organs more human-like. So transplantation research still continues. And then, of course, there's been interesting developments in mechanical pumps. Not really my area, but I'm aware that this field is also progressing. So to finish with, I want to look at the trials everybody forgets about, because they have very important lessons as well. Trials often tell us what doesn't work, what might be dangerous for our patients, what our patients might not need. And we often learn other things from trials that were not positive. And this is my alternative figure, which I don't show very much, which is the list of all of those trials that were a disappointment. Now, please don't say failed. They're disappointing, and I have to say I had a big part in many of these, sadly. But I want to pick out actually two of them, but one intervention, cholesterol lowering. So I'm going to pick out Corona and GC heart failure, because I think those two trials have probably the single most important message I've got for you because I want you to pass that on to your colleagues and get them to pass it on to their colleagues. So what is that message? Why am I highlighting corona and GC heart failure? Here are observational data. These are from hundreds of thousands of patients in the Kaiser Permanente healthcare system in California. And this was a paper published in JAMA that suggested that heart failure patients treated with statins had a lower risk of death and a lower risk of mortality. And you can see, if you look at the mortality slide, that this was true even if the heart failure patients did not have coronary heart disease. And if you look at the mortality rate, it was about 50% lower. A huge difference. And in fact, if you, as we did, went back and looked at our clinical trial databases, if you look at people taking statins, they do better. And in that Californian study, all sorts of adjustments, propensity matching, everything was done, and that apparent benefit of statins did not go away. And then, of course, we did 2 prospective randomized trials, and they were both as neutral as you can possibly get. The statin group and the placebo group here for all-cause mortality were identical. So the lesson here is that observational analyses of treatment are often, in fact, usually misleading. They often are wrong, and we have to really, today in particular, fight against that. And believe it or not, I'm going to Donald Rumsfeld as somebody who explained the problem of confounding. And there are known knowns, so those are variables that we know about and we adjust for. But what is most important is the known unknowns, and the unknown unknowns, they're the variables that we don't know about and that we can't adjust for. And that's the problem with observational analyses of the effect of treatment. You can never adjust properly for the variables that we know influence outcome, and you can never, of course, adjust for the variables that you either haven't measured or you don't know about. And therefore, observational analyses can never give us a reliable estimate of treatment effect. Turning to another Donald, who put it much more simply, which is basically observational studies are medical fake news. And truthfully, this is a huge problem for us at the moment, because with large data sets available, with sophisticated and inexpensive statistical software available, lots and lots of people are publishing analyses of observational data and making claims for those analyses. And in most cases, they will be wrong. So this is what we should be doing. I'm coming to a conclusion. This is really what we should be about. We should be about getting reliable evidence to inform our practice, inform guidelines, and implement that evidence. So I pointed out earlier the problem with implementation. We need not only to create the evidence, but we have to implement it. So randomized trials remain our best source of evidence to guide treatment. I admit that they're not perfect. They have inclusion and exclusion criteria. They select patients. There are many challenges, so the size and the cost of trials is often brought up, but of course that's often exaggerated by industry because it suits them to say that. And if you look at the diabetes world, when the US Food and Drug Administration said you will not be able to get approval for your glucose-lowering therapy unless you do a large outcome trial. There's been an explosion of very large trials. The money can be found if it needs to be found. Unfortunately, there are lower regulatory hurdles in other disease areas, and that's particularly true of cancer. And this is a really fascinating recent analysis that came out. And if you look at this slide, the panel to the far left of the slide shows you what people in the US die from. They die from cardiovascular disease more often than any other type of disease. Cancer comes second. Actually, I interestingly heard Joe Hill talk about this recently, and he said that he was sure in his mind that heart failure was going to become the predominant cause of cardiovascular death in his lifetime in the next 20, 30 years. If you look at the next panel, the one with the large yellow bit at the top, this is Google searches conducted in the US. What are patients, what are people, what are the general public, what are payers, what are administrators looking up? They're looking up cancer. If you look at media coverage, this is the New York Times, this is the Guardian, a British newspaper. What are they looking at? Yellow is cancer. These little blue bits at the top is heart disease. Everybody is talking about cancer. People forget the importance of heart disease. We have not done as good a job as we should do. We have to do better. So this is a problem. I've already mentioned real-world evidence, what I would call fake news. Industry loves that because they see that as a possible way of not having to invest in clinical trials in the future. I was actually at a meeting with the FDA to talk about the diabetes guidelines, and people from industry actually suggested that observational data may be an alternative to randomized control trials. There is a problem with funding because it comes from industry. In Europe, we do not have realistic, adequate funding to do our own trials. Our colleagues in America do. The US government still invests in large trials. We don't in Europe. Again, we failed as a group of physicians to persuade the authorities in Europe to invest in trials. But I'm convinced that we'll meet all of these challenges in the future. Thank you very much.
Thank you very much, John. Fascinating and provocative lecture, as you always do. We have a few minutes for questions from the audience, and while people get prepared, I do have a maybe more philosophical question for you, which is, out of all the trials you have conducted, which is the one that you would be most proud of?
It's either emphasis or paradigm. Probably paradigm, for obvious reasons. But I'm proud of them all, and it's not just me. These trials are obviously teams of people, investigators, patients. I mean, what I love about trials is the huge human effort that goes into doing them, and that's why they're so valuable, and that's why we have a responsibility to use them properly, to use those data properly, and also to implement the evidence if we show that there's benefit of treatment.
Well, congratulations. I'd like to ask you about a trial, because we have positive trials and negative trials, but there are some negative trials that give us the feeling of disappointment. And I'm talking about the TopCat study, because this is a negative or neutral study, period. But we have the strong suspicion that this trial is composed of patients with heart failure who fare better with spironolactone, people without heart failure, because nobody accept an 8% events in 6 years of follow-up of patient with heart failure. And there are two different approaches to the result of this trial, because the American guidelines say one thing or suggest one thing, and the European guidelines another one. What's the feeling of that?
That's a lot of questions. So you notice I didn't use negative or failure, I used disappointing, because I think you learn something from every trial, no matter what the result. And I believe TopCat had some important lessons, and one of them I've also learnt in another area, which is that unless you're very careful about the investigators you select, monitoring the sites, then you may end up with a trial that has issues related to its conduct. So it's not about the drug, it's about the conduct of the trial, it's about the selection of the patients, it's about the education of the investigators, it's about the motivation of the investigators. So trials are very complicated things to do, and to do them well is a lot harder than I think people realize. So I think TopCat, for that reason, is a lost opportunity. But TopCat was funded by the US government, which is good, but they don't have a lot of money for trials. And it did not get the same level of scrutiny and monitoring that a pharmaceutical company funded trial would do. That's a lesson, a very big lesson. Now, I think you also really asked me, do I think spironolactone works? I think it probably does. As you know, there are 2 ongoing trials with spironolactone at the moment. One is called SPIRIT, which is being conducted in Sweden, funded by the US government. It's a registry-based trial. And there's another trial called SPIRIT, but spelled slightly differently, which I think is a German trial with spironolactone as well. There may be a new trial with another mineralocorticoid receptor antagonist in HFpEF, possibly starting next year. I can only say maybe and possibly because there's no decision taken, but there may be. And in that case, there will be, if it goes ahead, there will be a large definitive trial that will clear up the answer to that question once and for all.
So John, as we get more aware about comorbidities and the growing epidemic of cancer in heart failure, which do you think are going to be the endpoints in randomized clinical trials in the near future? Cardiovascular death versus all-cause mortality, and also the fact of repeated hospitalization, which are more and more relevant rather than first hospitalization. So where do you think our cities are heading to in terms of endpoints?
Very good question. So we've sort of already moved to cardiovascular death in most of our trials, because even in HFrEF, more people are dying from non-cardiovascular causes. You've got to die from something, so cancer is the most likely alternative. And as you know, Tony, in HFpEF, we have, in the Paragon heart failure trial, also our primary endpoint in that trial is recurrent events. It's the first ever large-scale trial to do that for exactly the reason that you highlighted. But I also think that we need to go back perhaps to where we started, and that is to think a lot more about symptoms, quality of life, and functional capacity. We've kind of neglected that. There's a reason, because what happened, as you know, was that we had drugs that improved symptoms, improved functional capacity, got on the market, and then had to be withdrawn because they were subsequently shown to increase mortality. Fluoxetine was a good example of that. So this made the regulators very afraid about approving drugs based on symptoms and functional capacity. And as a result of that, we kind of forgot about symptoms and functional capacity and quality of life. But I think we've got lots of interesting new ways to measure functional capacity, so wearing wearable devices that track ordinary everyday activity. We have begun to understand how to assess quality of life better. So I think the time has come where we have to go back and say, if you're very elderly, if you're very comorbid, actually being able to do your ordinary everyday activities without being very symptomatic is probably as important an outcome as living a few weeks longer, because that's all it may be in some of these people, even with the most effective treatment. So I do think we'll have to reevaluate what is the priority here, what's the patient's priority as opposed to our view as cardiologists or the regulator's view as people who allow us to use drugs.
So if there are no more questions, I would like to ask to wrap up this session, Dr. Pinilla, the President of the Heart Failure Section of the Spanish Society of Cardiology.
Well, obviously, I'm not the Queen Elizabeth, and this is not the proper place for mention you as a sir or as a lord, but as a chair of our working group, it's a pleasure for me and it's a honor for our heart failure working group of the Spanish Society of Cardiology to mention you as the first honorary member of our working group for your contribution to the patient. So, thank you very much. Thank you. Just a little present. Thank you very much.
Muchas gracias. Con esto termina la sesión plenaria.